Hi, my name is Jack Crow. I'm an aortic dissection survivor and I am an aortic athlete.
And I'm Carmen David. I'm an aortic dissection survivor as well, and I'm an aortic athlete.
Carmen, good to see you.
Good to see
Hey,
you.
I want to wish you a happy 10th aortiversary. And maybe it'll be part of our discussion tonight, but that also means your lovely daughter must have just had a birthday. We'll get into that a little later.
Yeah,
Uh,
well, so actually now we're approaching almost the 11th aortiversary. So in May will be 11 years, and she turns 11 the next day, or I mean the day
wow.
before my aortiversary.
And in 10 years, you've run marathons, you've climbed mountains, you started this great run for aortic health in Fort Worth. It's raised hundreds of thousands of dollars for research into aortic disease. And I just want to say we're grateful to you.
Oh, well, thank you very much. Thank you. Yeah, I'm really looking forward to this year. If anybody else wants details, you can go to runforaortichealth.com. We're going to be having our 10th annual in August in Fort Worth. And of course, we have the virtuals that a lot of the aortic athletes and others around the country join in on. So we're really looking forward to it. So, but I don't know if everybody knows, Jack, that you have also completed a recent marathon. Um, for the New York City Marathon with the John Ritter Foundation. So congratulations to you. But I thought the last one was going to be your last marathon. So is this your actual retirement marathon, or are we
This was
still?
my retire. I am so old. This is my retirement marathon, 5 years post dissection, my last one. I'm not doing anymore. But as I told my wife, now that I have more free time, maybe I'll do some ultras. No, no, no.
Um,
I'm just kidding. I'm just kidding. Uh,
well, we'll see how that works out for you. Well, everybody, tonight, I've been looking forward to this topic on women, aortic disease, and exercise. But of course, before we get to that, just a few reminders. First, be sure to click like on the video today, and be sure to go to Aortic Hope and Aortic Athletes on Facebook and join those groups, and where you're going to find science-based evidence on aortic disease and, of course, great peer-to-peer support.
that's right. And as we always do, remember that tonight's presentation is for educational purposes only. Aortic disease presents itself in many different ways, and that's why what's safe for me might not be safe for you. So you need to check with your cardiologist about your exercise routine. So, Carmen, who is our guest?
So we are happy to speak with Thais Coutinho tonight, who is a practicing cardiologist whose focus is on the aorta, but especially related to issues with women and aortic disease.
And she's also, and I think this is recent, the chair of preventive cardiology at the Mayo Clinic and a professor of medicine there and director of the Aorta Center, the Aorta Clinic. And Dr. Coutinho is also an accomplished researcher in a wide variety of cardiovascular topics, including women and aortic disease. Dr. Coutinho, welcome. We'll turn it over to you for the opening, and then we'll come back and have some questions after that.
Thank you so much, Jack and Carmen. I'm really delighted to be here today and honored to speak to aortic athletes. And I would say my only disclosure for today's presentation is that I have never run a marathon ever. So you guys are way ahead of me when it comes to that. So thank you very much for the invite. I'm really excited to speak about this today. And I will just share my screen here. So let's see. Perfect. So we start with a brief presentation today, and then I thought of different things we could talk about today, and I just try to think of a topic that will be all-encompassing and hopefully helpful for a wide audience. So I kind of came up with this theme: living strong with aortic disease, exercising safely without losing who you are. And this is a theme that I have seen come across so many of my patients over the past, over a decade that I've been caring for patients with aortic disease. And for the ones that are athletically inclined, that seems to be always the common theme, right? How can I keep doing what I love without losing who I am and still keeping my aorta safe? So that's what I wanted to focus on today. And I have no disclosures other than, like I said, I have never run a marathon, and honestly, I have no intention of ever running one, although I have lots of other exercises that I do too. So just to make sure that we have a level ground in terms of terminology here when we talk about diseases of the aorta, aortic aneurysms and aortic dissection. So when we talk about aortic aneurysms, we are talking about the aorta, which is the biggest blood vessel in the body. As you can see here in the scheme, it starts in your chest and goes all the way down to the level of your belly button. And when the aorta widens and becomes bigger than its typical size, that's when we use the word aneurysm. However, you may also read in your report something called aortic dilation, aortic enlargement, aortic aneurysm. All of these tend to mean the same thing. So when the aortic aneurysm is in the portion of the aorta within the chest, we call this a thoracic aortic aneurysm, as shown here, or TAA. When the aortic aneurysm is in the portion of the aorta in the abdomen, we call this an abdominal aortic aneurysm, or a AAA. And when an aorta, typically an aortic aneurysm suffers a tear, which causes the blood to kind of seep out of the aorta into this new lumen that develops as a part of a tear, this is the process that we call an aortic dissection. And ultimately, that's what we want to avoid. Having an aortic aneurysm doesn't cause anybody any symptoms. However, it can predispose to this potentially life-threatening complication here, which is the aortic dissection or aortic rupture, and this is ultimately what we absolutely want to avoid. I thought I'd review with you some of the common causes for aortic aneurysms and dissection. And the top 3 are up here on top. When it comes to aortic aneurysms in the chest, the most common cause is high blood pressure as a combination of aging. Being an older individual with a history of high blood pressure, that's the most common form of aortic aneurysms in the chest. For the abdominal aortic aneurysm, smoking is by far the most common risk factor, in addition to being a man. And outside of high blood pressure and smoking, the third most common cause of having aortic aneurysms or dissections is something that we call a bicuspid aortic valve. The aortic valve is the valve between the heart and the aorta. 1% of the population are born with an aortic valve that only has 2 pieces. We call this a bicuspid aortic valve. Therefore, is the most common congenital heart abnormality. And anywhere between 30 and 50% of patients with bicuspid aortic valve also have an aortic aneurysm. So between these 3 here, these are the most common reasons why we see people with aortic disease. Then we have a bit less common, but still frequent enough that I see every week, some less common conditions, which are typically genetic. So we have Marfan syndrome, which is shown here. I think many of you may have heard of that. We have some other genetic syndromes, Loeys-Dietz syndromes. There are different forms of that. Turner syndrome. We have various forms of Ehlers-Danlos. However, the more dangerous ones for the aorta are what we call the vascular Ehlers-Danlos, or VEDS. And we can also have familial aneurysms, where the patient may not have any clinical features of any genetic syndromes. However, we can certainly see aortic disease kind of percolate through the family, and those are familial forms of aneurysm too. I also put aortitis here. This is probably the least common cause of aortic disease that I see in practice, which is an inflammation of the aortic wall, and that can also cause aneurysms and dissections. As Jack and Carmen had mentioned earlier, I have a special interest, both clinically and academically, in the sex differences in aortic disease. And I'm going to summarize this in one slide for you, but happy to discuss more in our question and answer at the end. So this is a very interesting paradox here, because in general, men are much more likely than women to develop an aortic aneurysms. As you can see here, if you look at all the patients with aortic aneurysm, about 70% or so are going to be male, and about 30% of them are going to be female. So that means that women have a relative protection against the development of the thoracic aortic aneurysm. The same goes actually for abdominal aortic aneurysm. However, if a woman escapes this natural protection that she may have against developing aneurysm disease in the aorta. So she escapes this protection and develops an aneurysm anyway, then the tables turn. The outcomes are worse. We know that a woman that has developed a thoracic aortic aneurysm has 3 times higher risk of aortic dissection compared to men with aneurysm, have 40% higher risk of death, and significantly higher risk of perioperative death, stroke, or perioperative complications if they have an aortic repair, either electively or emergently. Similar statistics can be demonstrated for patients with abdominal aortic aneurysms as well. So this is a paradox. Women are less likely to have this disease, but if they have it, they seem to have worse outcomes. And we can discuss during our Q&A period some of the many reasons for that. Now let's talk about aortic disease in athletes. What do we know about aortic disease in athletes? We know that if you take all of the athletes that have unfortunately suffered a sudden cardiac death, only about 1 to 2% of those can be attributed to an acute aortic dissection. So acute aortic dissection is much less common than other cardiovascular abnormalities as a cause for sudden death in athletes. So we have other things such as hypertrophic cardiomyopathy or other forms of cardiomyopathy or heart disease. We have anomalies of the coronary arteries. We have rhythm abnormalities. Those are going to be more common than aortic dissection as a cause of sudden death in athletes. And it's important that everybody recognizes that as scary as this condition is, most athletes will not experience this. So that's just something that is kind of grounding and reassuring, just to know that the majority won't experience, although there is a small percentage that will. The risk for aortic dissection in athletes is concentrated in those athletes that either have a family history of aneurysms or dissection, they have known genetic diseases that can predispose to aortic disease. Maybe they already have a known bicuspid aortic valve, or they are known to have existing aortic dilation. So it's very easy for me to say this, the risk is concentrated in these kinds of people. However, the reality is the majority of athletes don't know about this, right? We know that 88% of patients that present with an aortic dissection never knew they had an aneurysm to begin with. So even though we know the risk is higher in these individuals, most people do not know that they even have these risk factors, and that's something that we have to acknowledge. And lastly, the prevalence of an aortic aneurysm in athletes is really unknown because there's no programs for screening of the aorta in athletes. So that's information that we currently don't have. Now let's talk about the biomechanics of aortic failure. Let's get a little bit more physical and technical here, because obviously when we're talking about aortic aneurysm and aortic disease, what we fear the most is the failure of that aortic wall, which is going to lead to an acute aortic syndrome, such as an aortic dissection. In general, from a physics principle, we know that aneurysms will dissect or rupture when the tension in the wall of the aorta, or any aneurysm, exceeds the strength of that wall. So let's look at a definition, a physics definition of strength and tension. The strength means the maximum resistance that that wall has to external and inner tensions, and that's very much dependent on the healthy architecture of that aortic wall. And the wall tension is the force in the arterial wall that is the resistance, the force that's trying to expand it. We have no ways of measuring aortic strength in a live person. We can only measure aortic strength once we get a specimen of aorta and we can test it, in biomechanical testing. However, we can have a sense of aortic wall tension in individuals because we know due to Laplace's law that wall tension is going to be proportional to the diameter or the radius of the vessel. So the bigger the vessel, the higher the wall tension, and is also going to be proportionate to the pressure inside the vessel. So if we have a sense of an individual's aortic size, and if we have a sense of an individual's aortic pressure, we can have a sense of what wall tension tends to be. What we cannot measure, however, is strength. But if we can keep tension low, then we can prevent aortic failure or an aortic dissection. So let's see some examples of why an aortic wall would fail. So here's an example of decreased wall strength. So if you have decreased wall strength, it would take less tension to overcome that strength and cause an aortic dissection. And here's an example of a patient with Loeys-Dietz syndrome. Loeys-Dietz syndrome is one of the many genetic conditions that can predispose to aortic disease. It causes abnormalities in several connective tissues, making them more fragile, more pliable, and abnormal. And the same happens in the architecture of the aortic wall. So this aortic wall is going to be abnormal, the aortic wall will be weaker, and therefore we know that patients with Loeys-Dietz syndrome are at risk of aortic dissections even when their aneurysm sizes are not particularly very big. So that's an example of decreased wall strength predisposing to aortic failure. Now let's look at the other side of the equation, which is the increase in wall tension. Here's the classic scenario where an aortic dissection would occur. We have an individual that most of the times unknowingly may have an aortic aneurysm. Sometimes they don't, sometimes they don't. Most of the times they don't know they have it, but they really have really high blood pressure. So in this particular example here, the blood pressure is 192 over 105 millimeters of mercury, really, really high. I always tell my patients, we measure your blood pressure in the arm only because it's convenient, because your arm is here outside of the body and very easy for us to access. But we really do this because we're trying to understand what is the blood pressure in the aorta, because if it's going to be high in your arm, it's going to be high in your aorta too. So in this particular person, we really high blood pressure, we really have an increase in the wall tension that may surpass the wall strength and cause an aortic dissection. This is important because high blood pressure is the #1 cause of aortic dissections in the world. It is responsible for 2/3 of all aortic dissections that occur. And here is another example of increased wall tension. Here we have a very athletic individual. Perhaps they never knew that they had an aortic aneurysm, which is usually the case. And they are out there in the gym doing their heavy weightlifting routine. And when they're really doing really heavy lifting, the blood pressure peaks north of 200, sometimes north of 300, a really sudden peak in blood pressure. So now you have a significant increase in that wall tension that may lead to an aortic failure. So aortic dissections can happen in the setting of a really heavy weightlifting, and I have care for patients that have experienced this before. And it's important to know that in those rare situations where aortic dissection may occur as a result of a heavy weightlifting, when you look at all of those patients that experience that under those circumstances, and you look at the size of the aorta at the time it dissected, the average size of the aneurysm is only 4.6 centimeters, which is a small to moderate aneurysm in absolute terms. So this is to say that a really heavy weightlifting can predispose even an aneurysm that is not large to dissect. So that's another example of sudden increase in wall tension, surpassing wall strength, and causing an aortic aneurysm. So when we think of aortic dissection, we think of a two-hit model. Typically, you need to have two things happening in sequence, in a way, for an aortic dissection to happen. The first hit is to have a vulnerable aorta that has decreased wall strength, either because of years and years and years of hypertension or because of genetic predisposition. One of these things led to an enlargement of the aorta, an aortic aneurysm. Now you have a vulnerable aorta. And then the second hit is the sudden high aortic stress, which in the majority of the cases of aortic dissection, that sudden high aortic stress comes in the form of significant hypertension, but in other individuals, it may come in the form of significant physical strain. There have been patients that have had an aortic dissection when they were straining to go to the bathroom, for example. Others have had aortic dissections where they were lifting really, really heavy weights in the gym. Again, the majority would be hypertension related, but both of these will be a second hit to an already vulnerable aorta that can potentially predispose to the thankfully rare complication that is the aortic dissection. Now, let's think of the role of exercise for a person with or at risk for aortic disease. And now I see patients with aortic disease every week, and many times I'm seeing these patients either after they have already seen a cardiovascular provider, either a cardiology or a cardiac surgeon. And I cannot tell you how many times I've seen patients that come to me having received a guidance to say, don't exercise at all, or do not lift anything greater than 10 pounds. And they come fearful. They're fearful of sneezing, right? And we need to reframe that for all of our patients. And this is what I share with all of my patients, that exercise is absolutely essential for every human being. That is true for me. That is true for you. That is true for everybody walking on this planet. So not exercising is the worst advice I can possibly give to everybody, including a patient with or a risk for aortic disease. So our goal here is not avoidance of exercise. Our goal is smart adaptation. So when we think about smart adaptation, let's think about the different kinds of load that we can place on our aorta. What we consider a lower risk kind of load will be steady, rhythmic aerobic activity, the moderate continuous form of exercise, perhaps with some intervals, but not high intensity, but something that can be maintained. I'll give you an example. I have allowed some of my own patients with aortas of 5 centimeters even run marathons because, we came with an agreement that they were not going to try to PR, they were not going to try to do their best, they were going to go for a moderate continuous pace, and everything was okay. Moderate weightlifting or muscular endurance type of exercise is considered a lower risk exercise for the aorta. Activities such as stretching, yoga, those are not going to be high risk. What we consider a higher risk kind of load for the aorta will be really heavy weightlifting, significant straining of any kind that gets you to hold your breath. Some of you may have heard the term Valsalva maneuver, which is kind of this breath holding, tightening on the inside that we sometimes have to do for some forms of exercise. And any sudden maximum effort, whether that's maximum aerobic or maximum weightlifting, any sudden maximal effort will be a higher risk. So think of the load as smooth load versus spiky stress, right? We smooth load, the aorta can take that, no problem. Is the spiky stress that we get worried about. And just so you don't have to take my word for it, I brought you some data from papers. This is now from in the 1980s. I was a little toddler when this paper was published, and people don't do these kind of studies anymore. But in this study, the scientists, they actually were measuring blood pressure invasively with catheters in people that were doing leg press, as you can see here, to 90% of their 1 rep maximum. And they were doing that to failure. So here we have 2 separate individuals. And what I want to show you with this graphic is as follows. On the y-axis, you have the systolic blood pressure. So when they're starting out, systolic blood pressure is about 100, no problem at all, right? But as they do their super heavy leg press, the blood pressure goes to 300 in this individual. And as they keep lifting until failure, the blood pressure reaches 350 millimeter mercury in the peak. In one moment, is down here at 100, the next moment is 350. That's that spiky stress that the aorta doesn't like. The second individual did the exact same thing. As you can see here, blood pressure 100 when they're not pushing, but as they do the really, really heavy leg press, blood pressure significantly elevates. And in this particular person, the blood pressure went north of 400 millimeter mercury. So I wanted to show you this because there's method to the madness, right? So when I tell my patients, you can lift, just not the super, super heavy, is because this is what we're trying to avoid. We're trying to avoid those super big peaks of load on your aorta that are going to come from that super heavy lift. And those are the circumstances in which I have experienced in some patients aortic dissection in the presence of these types of really heavy lifts. Now, some of you are going to be endurance exercisers and endurance athletes. As you can imagine, for you to accomplish any difficult type of aerobic task, your blood pressure has to increase, right? Because if it doesn't, your brain doesn't get blood, your muscles don't get blood. So if we don't increase our blood pressure, we can't even exercise at all. So blood pressure increases are normal, expected, and needed for any of us to exercise, and that's not any different for the aortic athlete. But what I'm showing you here is a graphic of a systolic blood pressure on the y-axis as a function of the VO2 max. I think many of you in this audience will be familiar with the concept of a VO2 max, which is a measure of aerobic performance. This is here in milliliters per minute. Maybe you have heard of this number in liters per minute, like 25, 30, 35, 40, 45 liters per minute. So it just to show that the more that the individual, these are all athletes, by the way, the more that they accomplish in terms of their aerobic performance on the cycloergometer here, for example, the higher their blood pressure over time. In the squares, you have men, and in the dots, you have women. And as you can see here, if we push our capacity all the way to a super high VO2 max of 45 liters per minute, very often we're bringing a blood pressure, especially if you're male, into the 200 millimeter mercury. So that's why we talk about moderate continuous exercise with some intervals, but perhaps not those super high intervals that will peak your blood pressure as well. So what we consider an aorta-friendly exercise is the fact that the aorta tolerates consistent load, as shown here, better than it tolerates the sudden spikes. So think of steady and smooth instead of the spiky kind of exercise and load. So here's a summary of the exercise guidelines that I share with all my patients. And listen, I've been practicing as a aortologist, let's say, independently for, let me think, for almost 13 years now, actually. And I see patients with aortic disease every week unless I'm on vacation. And I give this exercise guideline to all of my patients. And I can say proudly that none of my patients have ever suffered an aortic dissection or cured aortic syndrome if they follow these exercise guidelines. And I can tell you all the ones that want to remain highly active are able to do so just with these very simple guidelines. So what are the guidelines? First, no heavy weightlifting or prolonged isometrics for the reasons I've already outlined in the previous slides. I tell my patients, if the weight is heavy enough that you can only do 4, 6, 8 reps, consider a slightly lower weight that allows you to do 12 reps, 12 to 15 reps. It's not going to be easy. By that rep 12 or 15, you're going to be really fatigued. However, you still have a couple of reps in reserve, right? So if you do that, you're able to keep good muscle tone. You're able to age gracefully and not lose your muscle as you get older. You're going to be fit. You're not going to be the biggest person in the gym, but you're going to be really fit. You're going to get all the benefits that you need from weightlifting without putting your aorta at risk. Now, the next is for aerobic exercise, and there's no kind of aerobic exercise that is forbidden. If you want to bike, if you want to swim, if you want to play tennis, if you want to run or walk or hike or elliptical row, choose your exercise. None of them are forbidden. We just caution against those extremes of exertion, right? So those peaks, those sprints to the finish line, the 10 out of 10 effort. I much rather have my patients perform in a moderate continuous exercise, perhaps with slight intervals without going to the maximum intervals, and they are going to still have excellent benefits from that exercise. They're going to get the mental health benefits, the cardiac and lung benefits, the muscle benefits, the bone benefits, all the good things without putting the aortas at risk. Again, I've told you I've let my patients run marathons with aortic aneurysms as long as they follow these principles. The third guideline here is to avoid sports with heavy blows to the chest. And honestly, in my 13 years seeing patients with aortic disease every week, I have only found one patient so far that actually fit this category, that participated in a special form of martial art whose name I already forgot, that included really heavy blows to the chest. The aorta is in your chest, so if we can avoid heavy blows to the chest, that's probably a good idea. So I say this here, but that honestly does not apply to the far majority of people. And scuba diving is actually something I've been experiencing more and more, and that's a tough one because there's really no hard, solid data. We have principles. We have physiologic principles that we follow. And as best as we can tell, and I have discussed this with my colleagues who are diving medicine specialists, I have read potential guidelines, and the recommendation is if your aorta is 4.5 centimeter or higher, scuba diving is not a low risk activity, and therefore we discourage it. I tell my patients, I give you some guidelines. The decisions are ultimately yours, but we do discourage scuba diving for large aortas, although snorkeling is absolutely fine. So these are very simple exercise guidelines. And as you can see, all of us, aortic athletes or everybody else, we can have really healthy lifestyles and exercise habits within those very guidelines I show you here. So here's a practical framework for you, the aortic athletes. First of all, make sure you know your numbers, right? You need to know where you stand. What's your normal blood pressure? Is your blood pressure, within your targets? What is the size of your aorta, the maximum size of your aorta? What are your medications that you're taking for your blood pressure and or your aorta? What are their effects? Are you getting the intended effects from them? So know your numbers first and foremost. Then favor consistency, favor moderate intensity, build your duration, not the extremes. You're still going to be very healthy, happy, and active even if you don't push necessarily to those super extremes. And 3, control the peaks for all the reasons I've been demonstrating to you today. Make sure you're breathing continuously through your exercise to avoid those Valsalva maneuvers and avoid those 10 out of 10 maximal efforts. And this leads us to my final slide here, which is a new mindset. Maybe I'm trying to read your mind here, but I'm just going to speak from experience of many of my patients have told me. Many of my patients, once they receive an aortic diagnosis, they feel fragile. They feel worried. I'm fragile. My aorta is fragile. My aorta is going to break. Let's have a new mindset. You are not fragile, right? You cannot change your aorta. It is what it is. What you are is strategic. You're now thinking about ways to continue to live your healthy lifestyle that you love in a very strategic way that is going to be great for you, but great for your aorta as well. Movement is medicine for all of us. For me, for all the aortic athletes, movement is still medicine, even if you have an aortic condition. And fear leads to inactivity. And inactivity is truly the worst thing any aorta patient can do, right? Sedentarism is not good for any human being. So fear leads to inactivity. Inactivity leads to worse outcomes. We want to avoid that. So let's think of a new mindset. You're not fragile, you're strategic. So let's think about it this way. So with that, I'm going to finish here with my take-home points that you can and should remain active after an aortic diagnosis. The risk mostly comes from uncontrolled peak stress that the aorta has to withstand with heavy, spiky loads. Exercise should be individualized. I gave you a framework here that applies to most aortic patients or patients at risk for aortic disease. However, at the end of the day, still talk to your doctor and make sure that this framework still works for you based on your own individual condition. And lastly, the goal here is strategy, not restriction. So thank you very much for your attention. I'll be happy to answer any questions from the group.
Thank you so much. That was terrific. I loved smart adaptation. Our version of that is our motto: don't quit, adapt.
Yes, perfect. I did not know that when I made that slide, so it looks like we're perfectly aligned.
Yeah,
Yeah.
we really are. I really loved how you were reframing that exercise is essential, because that is something that we try to tell people, like, the don't quit, adapt, and that movement is good. We're just trying to keep people moving and living their
Perfect.
best life. So yeah, that was great.
Wonderful.
Carmen, you want to kick us off here?
Yeah, well, and I wrote a bunch of things down too, because that was a great presentation. So some of the questions that we have here first, if we want to go over like your that are regarding more like your research, and sorry, let me get my thoughts straight here, because there was just so much I wrote down. That was great. For your slide on differences, sex differences in having aortic disease, are there any ideas why women have a lower, you explained a little bit about the lower prevalence of thoracic aortic disease than men and how they have worse outcomes. And then maybe if you can explain how that correlates with the importance of maybe still taking our medicines, especially the women, maybe as we age after having a diagnosis.
Yes, so I have lots of ideas. Ask if I have an idea. I have lots of ideas about why that happens. Um, so let's look at one side of that paradox, which is women are relatively protected against aortic disease. Why is that? We know the aorta loves estrogen. The aorta is full of estrogen receptors. And when it receives estrogen, which women are able, for the most part, to provide lots of estrogen to the aorta for many decades in a lifetime, estrogen is really healthy for the aortic wall. It really helps that aortic wall from adversely remodeling over time. There have been some very fascinating studies in animal models, and I'll give you some examples. For example, if you take two different mice, male mice, female mice, you just watch the aortas over time. The male mice aortas will grow faster than the female mice as they age. Same happens to humans. However, the experiment is such that if you take the aortas from one mouse and then transplant into the other mouse, right? Basically, you're just changing the environment. If you take the aorta from a female mouse and put it into another female mouse, everything's good. The aorta doesn't grow very much over the lifetime. But now if you take the aorta from a female mouse and now put in the body of a male mouse, completely different environment, completely different hormonal milieu, then the aorta starts to grow just like the male mouse. Similar, the reverse is also true. Take a male aorta, put it in the female mouse. Now the aorta doesn't grow much over time. It just really shows that the environment that the female body provides, and we're thinking estrogen, but maybe there are other things that we cannot even measure, really is protective against the aorta. And other experiments that have actually, instead of doing the transplant in the mice, they have created aneurysm models. So we can actually genetically modify mice to develop aortic aneurysms. So they can do that. And we know that if you take a male mouse and you inject them with estrogen, the aorta doesn't grow. If you take a female mouse and you remove their ovaries, the aorta grows. So that's why we have a sense that women have this protection, because most women, if everything, the first period, the menopause occur at the usual ages, women will have 30 to 40 years of heavy estrogen supply to the aorta, and the aorta loves that. So that's one side of the equation. Why are women relatively protected against this disease? That protection actually disappears once menopause commences. So once women enter menopause, obviously that's a period where ovarian hormones are no longer being produced at the quantities that were being produced before. Then these sex differences in aortic aneurysm start to balance out. So it's very interesting to see. Now let's look at the other side of that paradox, which is, okay, if a woman did develop an aortic aneurysm, they have more aortic dissections, more ruptures, they die more. Many different reasons for that, okay? Starting with the simple concept that women are smaller than men. And if you ever happen to, I should say always, but usually on average, women are smaller than men. So if you go and look at our clinical guidelines that we have to decide when should we repair the aorta on my patients, they are usually based on absolute numbers. You may see, 5 centimeter, 5.5 centimeter for majority of patients. They don't take into consideration that women are smaller with smaller aortas. So it has been shown that if you do a mathematical model to estimate what is the size of the aorta for the average woman to correspond to the aorta to the average man, say take a 5 centimeter aorta, which is a usual cutoff for surgery. A 5 centimeter aorta in a man corresponds to a 6 centimeter aorta in a woman. So now, because we were waiting for that woman's aorta to get to 5 centimeter, in the relative terms, we waited too much. We waited too long, right? So some of our women will have aortic events because our guidelines up to recently did not consider differences in body size when making surgical considerations. So that's one of the simple explanations. The other explanation as to why women may have more events, aortic events, and this seems to be predominantly in women that have what we call degenerative aneurysm. So now think about an older woman with hypertension, not necessarily the younger woman with BAV or with a genetic condition, but now think of the degenerative aneurysm, which is usually older menopausal women with hypertension. So what I'm going to tell you here seems to apply mostly to them. In these women, the aneurysm grows faster than men, and this is some of our own research that has shown that. The aorta is stiffer in an older woman than it is in a man. When you test aortic specimens after surgery, do the surgery, take a piece of the aorta out before the repair, and then let's go test it in the biomechanical lab. Women's aortas are weaker and stiffer, so they're sicker. So here's a paradigm that I've created this, but I'm going with it. I've been showing this in every presentation I ever give is, if a woman who has a natural protection against aortic disease somehow develops aortic disease anyways, maybe that is a sign that that aorta was sicker to begin with, right? Because if the bar to develop an aneurysm is up here, men are up here, women are down here, for the woman to cross that bar, she needs to bring more disease into this aorta to cross that bar. So I usually think of a woman with an aortic aneurysm as a person whose aorta is probably sicker. And this probably is more significant in those patients with degenerative aneurysm. And lastly, women undergo, not every woman, but many women undergo pregnancy. Pregnancy is a woman's first stress test in life. There have been a study. I wish I could quote the exact study to you guys. I forget now the author, but I read it a few years ago, where it was exercise physiologists, and they wanted to test the boundaries of the human body. How much can you push the human body until it literally breaks? And they found that there were two conditions that brought the human body into its absolute physiological limit. One was ultramarathon participation. The second one was pregnancy. So being pregnant is equivalent to running an ultramarathon, right? So in terms of the stress that it imposes on the cardiovascular system, it is really a person's first stress test. And if a woman already has a predisposition to aortic disease, that first stress test, which is that pregnancy, may uncover that aortic disease. So that's another kind of female specific aspect of aortic disease. So super long answer here. As you already know, I have given 45-minute talks on this very topic, so I could talk forever. But these are some kind of pieces of the puzzle, and we're still, of course, learning more and more as we go.
Oh, wow. That's really interesting. Well, and actually, I dissected 22 hours after I delivered my daughter spontaneously. So I'm in that boat you were just talking about, which leads me actually to a next question. So there's a lot of questions from women on hormone therapy, whether that is after a dissection, whether really a diagnosis of an aneurysm or having had a dissection, on whether hormonal birth control is advised or not, and what is the update on that? And then going to the older aspect on when it's time for menopause, what is the advice around hormone replacement therapy for women at that age?
Excellent
Like
question.
what's safe and what is, is there any research and stuff out there for us?
Yeah, excellent question. So, to my knowledge, there is nothing to indicate that hormonal contraception predisposes someone to aortic dissection. There are some other kinds of cardiovascular diseases whose incidence may be increased by hormonal contraception, the most common one being blood clots in the veins, in the legs, or in the lungs, for example. But there's no data to tell us to suggest that taking hormonal contraception predisposes to an aortic aneurysm or dissection. So in a very pragmatic way, this is how I think about. If I have a woman with aortic disease in front of me, pregnancy will be much higher risk than taking a contraceptive pill, right? So I advise, we always have a talk about contraception or whether pregnancy will ever be safe for that person, yes or no. Everybody's different. But I am much more inclined to support their contraceptive plans. And people have choices, thankfully. They can have IUDs, they can have other forms of contraception, or they can have a pill or a patch. And I'm supportive of them using a pill and patch to prevent pregnancy because the pregnancy will be a much higher risk situation on the other end, right? So I have not contraindicated that to my patients if that's the choice that they choose, for their family. Now, the second aspect of your question was about the hormone, menopausal hormonal therapy, right? So much is changing in this field. I would just summarize to say that in the aortic world, there's really no data to suggest that menopausal hormonal therapy is detrimental to the aorta. So I tell my patients, if you have an indication for it, for any reason that it is, I have no worries about it. Go ahead and take it, right? We know that menopausal hormonal therapy has a lot of benefits for some women. Everybody has a different condition, but I do not think that an aortic condition is a reason for them not to pursue that if they need it for any other reason. There is data because of course, I study aortic health and aortic stiffness, within the aneurysm world, but also outside of the aneurysm world. And within that aortic health and aortic stiffness perspective, there is evidence to suggest that hormonal therapy can actually be beneficial to the health of the aorta in terms of aortic stiffness and so forth. This is not enough evidence for me to recommend it for that reason, but it just helps me look favorably at it because I have no reason to think that this is going to harm my patient, and maybe it could help. So nowadays, this is such an evolving landscape. You may have seen the news. So all this to say that if my patient in front of me needs menopausal hormonal therapy for whatever reason, typically, for the far majority of my patients, I cannot imagine their aorta getting in the way of that.
And would that include testosterone for really both men and women?
That's a whole different can of worms, okay? So I'll speak to women. So for the aorta, there's no data. Testosterone is different because testosterone may raise blood pressure. Ultimately, blood pressure is the biggest enemy of the aorta. Estrogen does not raise blood pressure. Estrogen, in fact, may lower blood pressure. And that's why we have lower blood pressure in our younger years than we have after menopause. Testosterone, however, can raise blood pressure. So have to think about it. I'm thinking of the blood pressure as my ultimate goal that I want to control. The evidence for testosterone supplementation for women, it's still really a very kind of smoke and mirrors aspect. I know there's a lot of talk about it, but I'll be lying if I came to you today with a conclusive answer of what is right and what's not. I personally do not prescribe or support testosterone replacement for my patients with aortic disease because I don't see strong evidence for it, and I'm concerned about the blood pressure. Now, for our male patients, I recently actually read a meta-analysis study that looked at multiple previous clinical trials and studies of male patients that have hypogonadism. So what is that? They have had a measurement of their testosterone level, and testosterone is low and is associated with symptoms associated with that. So that's what hypogonadism means. So in men with clinically documented hypogonadism, receiving testosterone therapy did not prevent cardiovascular disease, but also did not cause cardiovascular disease. It was pretty neutral. So if anybody was thinking about using it because they're thinking, oh, if I replace my testosterone, I'm going to prevent a heart attack and stroke. No, as best as we can tell, you won't do that. But it also, as a clinician, it helped relieve some of my own concerns that if they were to replace, they could, accelerate heart disease, and the evidence is not showing that either. So it was pretty neutral. So that's for men with documented hypogonadism. We do not have data for men without hypogonadism that are taking testosterone for athletic pursuits. That data we do not have.
Awesome. Well, thank you for all that. Jack, do you have any other questions related to something else besides hormone therapy?
Yeah, I was, well, I'll ask a question and then maybe we can do a rapid fire on all of our aortic athlete questions. We'll get to some of those.
Yeah.
So I was wondering, is there something about the way women present at the ER that they're being diagnosed differently or treated differently? We hear anecdotal stories about people, women, and some men, but women, I would say, being sent home with indigestion when in fact
Mm-hmm.
they have an aortic dissection.
Mm-hmm.
Is there something about the clinical practice uh,
Mm-hmm.
here as well?
So that's an excellent question, Jack, because and this doesn't apply just to aortic dissection. This is actually very well known also in the field of heart attacks and heart disease, because both conditions ultimately present with chest pain for the most part, right? Heart attacks and aortic dissections. The reality is there's still a lot of misinformation out there in the world, both at the level of the public and at the level of providers. And there's still this concept that women don't get cardiovascular disease, right? Actually, studies have shown this that if you just go out there and start interviewing women, what do you think is the biggest threat to your life? And you interview people and you write down the answers. Um, 60 to 80% of women will say that the biggest threat to her life and to her health is breast cancer. When the reality is that cardiovascular diseases kill 5 times more women than breast cancer does. Cardiovascular diseases kill twice more women than all cancers combined. And cardiovascular diseases are the top killers of breast cancer survivors, right? So at the level of the public, there's this misinformation that women don't quite yet, despite all the campaigns that we've had over the years, they quite don't understand that yes, they can have cardiovascular disease, whether that's an aortic dissection. Most people don't even know aortic dissection exists, right? And the data I'm telling you is mostly for heart attacks. So that's that. And the providers too. No, you think, I'm just looking at Carmen here. She just shared with us that she had an aortic dissection. Now, she was postpartum, so there's usually some more suspicion in that situation. But imagine a young woman coming in with chest pain. Providers are not usually thinking bad cardiovascular things are going to happen to young women, right? Because women have this relative protection against cardiovascular disease. So this leads, all of this misinformation, biases lead to delays in diagnosis. So that's one aspect of it. In the specific field of aortic disease, we know that because I told you that women are relatively protected against aortic disease, right? But I told you that after menopause, that relative protection kind of disappears after women enter menopause. So what we do know about women presenting with aortic dissection is that women tend to be older than men at the time of their presentation, and they can present with more comorbidities. So because you're older, you're more likely to have, say, maybe kidney disease and diabetes, and as compared to a younger person. So some of these changes in outcomes are not just because of delays in diagnosis, but also because many of women presenting, they're also older with more comorbidities. And these are some of the things that we can measure. There are probably things that we cannot measure and we don't know yet that are also influencing some of those outcomes.
All right, let's go and we'll kind of do rapid fire here, Carmen, to some questions from aortic athletes. Aortic athlete Elizabeth asks, what should we monitor during and after exercise? Heart rate, blood pressure, or perceived exertion? Maybe
I
all of the
think
above.
I think in my talk I mentioned perceived exertion, right? Because first of all, you can measure your blood pressure during the exercise. It's hard for us to even measure when somebody's doing a stress test, and I have to be there measuring myself. It's super hard. So don't measure your blood pressure during exercise. The heart rate is mostly a guidance for you about your intensity, but if you're in good if you're in tune with your perceived exertion, that's what I counsel my patients on. So I will go for perceived exertion.
Yeah, I in the New York Marathon, I could carry on a conversation the entire way. I
Yeah,
could,
that's how I know you are in a light pace.
yeah, yeah.
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 Okay, aortic athlete Glenda asks, on lifting weights, with all the emphasis on correcting heavy lifting by men, how should women lift safely? Lots of
Same.
reps, medium weights. what's the medium weight for a 5'2" female with a 4.4 ascending aneurysm? Well, we won't
Well,
get into it, the
that's too
specifics.
specific.
Yeah.
So, but everything I spoke about in my talk applies to men and women. I do not give female specific advice because the aorta only knows pressure. And those things I talked about are the things to protect the aorta from reaching peak pressure, peak stress, peak tension that goes for men and women. Now, one of the questions that this athlete mentioned is, oh, what will be the right weight for me? I tell you, my patients ask me this all the time. How much can I weight? My answer is, I don't know. Because even in my own body, my shoulders can lift a certain weight. My hamstrings can lift a much higher weight, right? So there's not one number that applies to even my whole body, right? Because it changes depending on the muscle group I'm using. So let alone inter-individual differences. So I cannot give people a number. I do not give any of my patients a number. I say, you pick up whatever you're doing. If you're doing shoulder, back, leg, whatever you're doing, pick up a weight that allows you to do 12 to 15 repetitions that is still going to make you tired, but you still have a couple of repetitions in reserve. Whatever that weight is for that muscle group is the right weight for you.
Okay.
Carmen?
Awesome. That kind of goes along with this one. So Mary was asking about leg presses, and you mentioned leg press in that slide about the it going up and down. But if a physical therapist or you've got a knee injury or something like that, and they're being told to lift a certain amount of weight for helping said injury, then should you decline or, of course, disclose what maybe aortic disease you have? How should a patient approach other unrelated illness when they
Yeah.
have to do weights?
Disclosure is always a good thing, right? If you're working with a healthcare provider of any kind, it's good that they know all of the aspects of your health so they can help you best. I would not discourage a patient for doing a leg press. That study I showed you of the leg press they were doing 90% of their 1 rep maximum, right? So imagine how heavy those lifts were, right? And the reason they chose the leg press for the study is because they had the catheter inside the patient's arm. So they had to keep the arm immobile. So they had to do the leg press. So I don't want the leg press study to scare people against doing leg presses. But again, that was a 90% of the 1 rep maximum. So if you had an injury and you're doing physical therapy, I can guarantee your physical therapist is not going to put you at 90% of your 1 rep maximum, right? The therapist is probably going to suggest very similar framework to what I suggested today, a more moderate weight with 12 to 15 repetitions, and that would be perfectly safe to do even for a leg press.
Okay, great. And Laura Marie asks, are there any different exercise recommendations for women that are pre or post-menopausal? Like, should they be doing anything any different or depending on their age for their exercise?
We should all be doing the same things. We should all be doing, this is what I do. I practice what I preach, and that's what pre-menopause, post-menopause, we should all be doing. We should all be doing 150 minutes of moderate exercise a week at a minimum for aerobic conditioning for heart and lungs. We should all be doing a minimum of 2 and preferably 3 days a week resistance training. So 20 to 30 minutes of resistance training to make sure that we do not lose our muscles as we get older, because sad news here, comes age 35, we all start losing muscle. So if we don't keep fighting for those muscles, they go away. So we have to incorporate those 2 to 3 resistance training sessions per week as part of our training, according to those guidelines that I suggested today, and stretching, right? If we don't stretch, we lose range of motion. If we lose range of motion, we become that older person that is stiff, falls, breaks the hip, right? So pre-menopause, post-menopause, this is what I recommend to you, and this is what I do myself.
Great.
Aortic athletes, Mary and Jane, let's say hot tubs and yoga. And full disclosure, I do yoga, but I ease into it. I do a lot of breathing. It's more intermediate. I don't rigidly hold poses till I start, shaking.
Yeah, for sure. And I will be very candid that I actually do yoga every day, but I do yin yoga because I like to use yin for my stretching. And I've never really gotten into the really, I think Hatha yoga, I think is the flows, and those can be pretty severe. So I would think for those, if you need to be holding a pose in a real isometric hold for a really long time, maybe that's the one thing that I would avoid in yoga. But for the most part, a yoga is not a high risk condition. I would not discourage people from doing yoga. And I do yoga myself every day. The second question had sauna and hot tubs. Is that what you asked? No concerns from an aorta perspective. Just know that if you are taking medication for blood pressure, so many aorta patients are going to be on a beta blocker or on an angiotensin receptor blocker such as losartan. These are blood pressure medicines. Just know that your blood pressure responses will be delayed. So when you're hot in the hot tub or in the sauna, you're going to vasodilate, right? You're going to be red. That means you're vasodilated. That means your blood pressure will be lower. So as you get out of the hot tub and out of the sauna, it's going to take a little longer for your blood vessels to kind of readapt. So just be careful so you don't get up too quickly and faint, right? That's the only concern. It's not an aorta concern. It's just make sure that you're kind of easing your way out of the hot tub and easing your way out of the sauna so your blood pressure doesn't drop too far and you faint.
Okay, and aortic athlete Mike is asking kind of a crystal ball question on AI, artificial intelligence. What's on the horizon? Valve repair, replacement, surgery. How's AI going to be utilized in 5 or 10 years, do you think?
Well, AI is already starting to percolate through the aorta world from a diagnostic perspective. There are already some AI models that have been trained to read CTs and MRIs of aortas, and the evidence that's coming out is that they can actually measure aorta just as well as a radiologist. So that's good, right? Because it saves the radiologist time and it helps, and it can actually measure in multiple segments, and it can probably very accurately quantify growth over time. So that is already starting to penetrate into our clinical practice. What we want out of AI is, can we eventually develop an AI model that can predict those aortas that are going to misbehave in the future, right? Because I have 2 patients with aortas of 4.8 centimeter in front of me, maybe one, the aorta hardly grows over time, very slowly. The other one dissects. How can I tell, right? I study aortic function. I try to understand this through aortic function, but I think there is a very good possibility in the future. The future is not yet today, but there's certainly a lot of minds thinking about this, of how can AI help look at all echoes and CTs and MRIs and try to find vulnerable aortas that the human eyes cannot perceive and help understand. So that is something that we are excited to see develop over time. Hopefully not too far from today.
Great.
Carmen, how about a couple more, and then we'll you ask a couple and we'll wrap it up. Hey, by the way, Dr. Cody M. from Canada, a cyclist, was a patient of yours up in Canada. I think we had several Canadians who are aortic athletes who wanted to say hi to you, including
Well,
Cody.
hello, and hi to Cody. I follow you on Instagram. I'm very proud of all you've done.
He's a cyclist. Yeah, he's very good.
I know that very well. Yes.
Yeah, awesome. Aortic athlete Amber asks about GLP-1s. So is there any research on weight loss drugs and their positive or negative impact on the aorta?
No study in humans, but I coincidentally just read a study in animal models last week. Remember, in science, everything starts with cells, then animal models, then large animal models, then humans, right? This is how science evolves. So I read last week our very first research study of GLP-1 inhibitors in animal models of aortic aneurysm, showing that I believe it was tirzepatide actually that was being trialed, that actually prevented aortic growth in animal models of aortic aneurysm. So I was very happy to see that. So there is, I mean, everywhere we look, as a cardiologist, everywhere we look at these GLP-1s, we've been pleasantly surprised about the things we have found. We have found that, yes, they help people lose weight and they help control diabetes, but they also prevent heart attack and prevent strokes, and they decrease vascular inflammation. And all of these positive effects seem to be independent of the patient's initial weight or the magnitude of weight loss. So the more we've been studying these drugs so far, there have been no oops. We have not found any oops, we shouldn't have done that. We have only been finding, wait, this is great. So we've been very excited about GLP-1s. And I saw this study last week on the animal models of aortic disease with tirzepatide, and I was very encouraged. So stay tuned. I'm sure clinical studies will follow.
Awesome. Thank you for that.
Mm-hmm.
Matt asks about post-repair exercise for people with a connective tissue disorder, having an LOX variant, surgery 4 weeks ago. Where do I draw the line on activities or distances once recovered from surgery? And how long should I wait until I get back to normal exercise routines like running and cycling?
Okay, so LOX is one of the mutations that can cause familial forms of aortic aneurysm. I cannot give the specific advice that these athletes asking because that is the role of the cardiac rehab program. So hopefully they have engaged in their cardiac rehab. Every single patient after an aortic surgery should engage in cardiac rehab. Cardiac rehab is wonderful. It helps get you back to on your feet, get you back to your activities, and it helps decrease future cardiovascular events. So hopefully that athlete has been participating or has participated in cardiac rehab. And during that process, they were going to work with him or her to kind of progress them over time. And eventually, once they graduate from cardiac rehab, then depending on their situation, if there's no other caveat to it, they can follow some of the principles that we discussed during my presentation today.
Okay, great.
All right. A couple of quick, I'll wrap a couple quick together here and then we'll close. Amanda and let's see, Nancy and a couple of other folks are asking about specific things like sit-ups or reformer Pilates, where you're using straps and weights, which is more challenging. I think your general thing is about, it seems, moderation.
It applies. I've never told any patient not to do Pilates. What was the other type of exercise you mentioned there?
Sit-ups, post-type A dissection.
You can do sit-ups. Yeah, no, again, we maintaining a strong core is important for all of us. So doing sit-ups is okay. Doing Pilates is okay, as long as you follow some of these principles. Moderate, no long isometric holds. Moderate efforts with more repetitions, going to keep great muscle tone, keep your aorta healthy at the same time.
And last one, Nancy, Carmen and I are flatlanders. I'm in Chicago, she's in Texas, but we have a lot of Colorado, Rocky Mountain people who are up at higher elevations. Any concerns about maximum heart rates at higher elevations with hiking or blood pressure?
So I don't really think about the heart rates for my patients for the most part, because the heart rates is a reflection of their effort, right? So if they learn how to work with their effort, the heart rates will follow suit. So I'm less prescriptive about heart rates. We don't measure our blood pressures. The altitude itself is not necessarily a big problem for an aortic athlete. Patients that have problems with blockages of arteries, because of course, if you have a blockage, you have less supply of oxygen coming into, let's say, blockages to your heart arteries, then you have less oxygen, and then you go into a high altitude, you have even less oxygen. I worry more about those types of patients, patients with coronary artery disease and heart attacks. Patients with aortic disease don't usually have that concern. So the altitude itself, I mean, I have patients that live in altitude even, and that's okay. So I wouldn't be prescriptive about the heart rate. I would be more in tune with the effort. And this is a framework that I also like to explain to my patients. So if you're out and about, hiking, out in the woods, doing whatever it is that you want to do, let's say you're hiking with a buddy, right? So you're hiking and your buddy is chit-chatting with you and you can have a full-blown conversation with this partner. Great. That means you're in a light pace, no concerns at all with the pace, right? So that's you running a marathon, right, Jack? That's impressive, by the way. That would not have been me if I was running a marathon. So that's a light pace. So if you can have a full-blown conversation while hiking or doing whatever else that you're doing out there, perfect, not a concern. Now, let's say the hike is a little bit steeper or a little bit more difficult. Your buddy's still with you and the buddy's yapping away, they're talking to you, but now it's harder. Now you can say a sentence and then you got to return to your breath. So you say blah, 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 blah. I have to breathe a little bit again. And then blah, 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 blah. A sentence at a time, then breathe. That tells me you're in a moderate pace. Moderate pace, no problem. Keep on doing that. Now, imagine the hike got steeper now, or you've been hiking for a long time and you're really, really tired. Your friend's still yapping and talking to you, but now you cannot say any words back to your friend, or at most you can say a word. Okay, say yes, no, and then you have to breathe again. That means it's a pace that you're probably past the pace that I would like you to be in, right? So this is something that I will use for the hikers out there or any other exerciser that is just trying to understand what kind of effort they're in. Full-blown conversation, light pace, no problem. One sentence at a time, moderate pace, no problem. No words or only one word, you've gone too far. Slow down a little bit.
Well, that's a great test, and also that our fitness is not set in concrete. That if you little by little by little by little, you can increase over time, over months, and improve your fitness as well, and be able to do a little bit more, go a little faster as you build your fitness. Well, Dr. Thais Coutinho, we're going to call you a friend of aortic athletes now.
Oh, thank you. Okay. I consider myself an aorta athlete. I have an aorta, and I'm an athlete of my basement. So can I be part of your group?
Absolutely.
Of course.
Oh, perfect.
You got to pass the 2 admissions questions. You got to describe your aortic disease and what your exercise routine is. We'll see how you do.
You know, I can pass. See, I have a bovine aortic arch. Have you heard of this before?
No.
Okay, so it's not an aortic disease, but it's a variant. So sidebar, I know because I have a bovine aortic arch because once when I was younger, I was volunteering for research when I was a fellow, and I had a cardiac MRI, and then that's how I saw my aorta, and I have this is variant. So if you think of the aorta, the aortic arch. Will be 3 branches that come out of the aortic arch, right? One is, we call it the brachiocephalic artery, also called the innominate artery, that will separate into the right carotid artery going into the right side of the brain and the right arm, right subclavian artery. So that's one branch. The second branch out of the arch is the left carotid artery going to the left side of the brain. And the third branch out of the arch is the left subclavian artery going into the left arm. So that's the normal arch anatomy. Some of us, myself included, have arch variants where we don't have those 3 branches. We may have just 2 of them or just 1 of them. Unfortunately, the name bovine has been used because cows only have 1 big trunk. So basically, imagine the arch, and they have 1 trunk of vessels that come out of the arch, and that trunk gives all 4. Okay, so that's how cows are. That's not how we're made, but that's the name that nowadays people are using the term arch variants because bovine arch was just terrible, right? But anyways, so I have that. So basically my innominate artery or my brachiocephalic artery, instead of bifurcating into my right subclavian and right carotid, it trifurcates into my right subclavian, right carotid, and left carotid. And then I have a second vessel that goes into my left arm. So my aortic arch only has 2 vessels, and that's what is called a bovine aortic arch. That is considered a variant of normal. So it's not to cause alarm. However, interestingly, and I only know this because I'm an aorta expert, when you look at patients that have aneurysms and dissections, there is a higher proportion of bovine arch anatomies in those patients as in the general population. So for that reason, I have a look at my own aorta every 10 years, which is okay. My aorta is normal. But I do have, see, I passed the test for the aortic athletes. I can describe my aortic problem because I have a bovine arch, and I can describe my exercise routine, which I already told you earlier today what I do. So here we go. I can be part of the group.
Carmen, what do you think? Should we let her in?
I think she passes. Perfect. Okay. That's interesting, though.
Yeah, it's amazing, right? We always joke in medicine that the doctors always seem to have a disease that they specialize in. And I thankfully don't have an aortic aneurysm of dissection, and I know because I've looked, but I do have a bovine arch. So here we go.
Yeah.
Well, listen, this has really been fun and informative, and we'd love to keep in touch with you as we go along. We'd love if you became a member of Aortic Athletes too. So
Right.
thank you so much, Carmen. You want to
Yeah,
send us?
thank you guys. Yeah, thank you guys so much. Thank you for joining us in that wonderful presentation. If anybody wants to Google search on YouTube, I did so earlier and was listening to some other great videos that she has out there. So try to look her up and see what else you can find. But stay tuned for the next Aortic Athletes interview. I'm not sure who we'll have, but I'm sure it will be also interesting. So thank you guys very much.
Good
Thank you
night.
for the invite, and thanks to the aortic athletes. Keep your aortas healthy.
Thank you.
Bye,
Thank you.
everyone.
Good night now.